I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Hegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
This is a 65-year-old postmenopausal woman that has metastatic triple-negative breast cancer who's presenting with progressive chest pain while receiving second-line systemic therapy with carboplatin and gemcitabine. And so the question that we're really going to be focusing on is what is the therapeutic strategy that we would recommend for this particular patient. So her history begins in 2014, at which time she was diagnosed with a right triple-negative breast cancer. At that time, she underwent bilateral mastectomy, was found to have a positive margin after the original partial mastectomy, and so had bilateral mastectomy. She received adjuvant radiation and chemotherapy with doxorubicin and cyclophosphamide, followed by paclitaxel. In 2018, she began experiencing new chest discomfort. Imaging at that time demonstrated a large mass eroding into the sternum and several osseous metastases. Her laboratory parameters at that time were within normal limits, and PD-L1 testing was completed and was less than 1%. In March of 2019, she began treatment with capecitabine, and then in September of 2019, progressive disease was noted on physical exam. At that time, her treatment was changed to carboplatin and gemcitabine. In February of 2021, she now presents with progressive chest pain. Still, her blood counts and complete metabolic panel remain within normal limits. So I'm going to ask Dr. Jockelson if you could sort of walk us through some of the imaging for this patient with this kind of large thoracic metastasis.
So what we have are two slices of a CT scan of the chest at different levels. The first one is the one with the lung windows, and I think really don't see as much in the lung parenchyma itself. So she has bilateral breast implants. The one on the left has this calcium, which just indicates that it is encapsulated. Anterior to the one on the right, there is a low attenuation mass, which also has some calcifications. It looks benign. It could even be a walled-off rupture. It's hard to say, but I don't think it's relevant for this patient. The big problem that she has, you can see that she has this partially calcified mass in the medial to the right breast implant. It is in the region of the sternum, and you can see though that this mass, which is going from the breast tissue through the chest wall into the anterior mediastinum. I'm sure the internal mammary nodes are involved, and then there's additional tumor in the anterior mediastinum in the paratracheal region. So she may very well have had an internal mammary node that grew out of control, but having disease in the mediastinum, et cetera, certainly consistent with distant spread.
Okay, thank you so much for that. So this patient, very symptomatic, from this this large kind of chest wall mass. So maybe Dr. King, if you could comment for us, do you feel like there's a role for surgery at all here? Would that have a palliative role for you at all, or is that prohibitive given the presentation?
Thank you. Yes, this is a very unfortunate situation for this patient. Unfortunately, surgery is really not a good option for local control or symptom palliation in this setting. It would require a quite extensive chest wall resection, which is associated with significant morbidity. And really, this patient's best option is to find a systemic therapy approach to control this disease.
Okay, thank you so much. So with that, Dr. Pegram, Do you have some recommendations for us, having had this most recent progression with carboplatin and gemcitabine? What are your thoughts?
Well, the first thing I would ask is for my colleague, Dr. Shaw in radiation oncology, to do a consultation in this case, because she does have significant pain and high disease burden. And so one wonders, could she first benefit from some palliative radiation? You want to comment on that first before I go on with her systemic choices?
Sure. I think that radiation therapy here does offer the chance for palliation. She did have radiation in 2014, but this being 7 years later, that's not a major concern. I would radiate her. I would probably escalate my dose. I don't think standard palliative doses, given the gross extent of disease, is going to provide her a lot of palliation. And so I would treat her probably in a higher dose per treatment regimen, counseling her that she's likely to have significant contracture of her implant because this mass sits right next to her implant. So I'm likely to cause capsular contracture and potentially cause subacute and chronic fractures of the sternum and chest wall.
So the other thing to think about is it's easy to just attribute the pain to disease progression, in the sternum. However, there have been case reports in the literature of acute myocardial infarction, arrhythmias, and pericarditis, even a cardiomyopathy from the use of gemcitabine, which she's on. So just for completeness, I might do an EKG or even a cardiac echo in a case like this to rule out any other cardiac causes of chest pain. She is 65 years old. We don't know her family history, so that would be useful as well. Like in the last case, I would make sure that she's on a bone-acting agent. She does indeed have sternal metastasis, to be sure. So either denosumab or bisphosphonate is indicated in terms of systemic control of her distant bone metastasis. Next, in terms of treatment, she's had a lot of chemotherapy already: adriamycin cytoxan, paclitaxel, gemcitabine and carboplatin, and capecitabine. And so now there's a new antibody drug conjugate, Sacituzumab govitecan. This drug is an antibody that binds to a target called TROP2, which is nearly ubiquitously expressed on triple-negative breast cancers. Following binding, the antibody drug conjugate is internalized inside the TROP2 positive tumor cells, and it releases a chemotherapy payload called a topoisomerase 1 inhibitor. And so this can be very useful in patients with prior chemotherapy with triple-negative breast cancer. It has an impressive response rate, good durability, and good tolerability. While it does have some chemo-like side effects, like cytopenias, a little fatigue, some hair loss, etc., it's still generally very well tolerated compared to most other chemotherapeutics. So I think it would be a drug of choice in the non-clinical trial setting for a case such as this who's progressing on gemcitabine and carboplatin with metastatic disease. The other option is always a chemotherapy, clinical trial option rather, if available. And then also if she hasn't had next generation sequence analysis with genomic testing, then a foundation assay or other commercial NGS assay might be useful at this point for future considerations, both for clinical trial and for compassionate use treatment of targeted therapeutics, perhaps.
Okay, thank you for that, Dr. Pegram. And I'm assuming because of the triple negative phenotype, you would be in favor of genetic testing to look for a targeted treatment with a PARP inhibitor if that was appropriate based on those results as well. Is that something that you would do as a standard part of your metastatic workup?
Yes, I would indeed. Yep, absolutely. That would be indicated in a case such as this.
Okay, perfect. Thank you all for your thoughts.